I have the pleasure of introducing Shoumi Saha. She has quite a lot of accomplishments, so bear with me, this will take a minute. She's a pharmacist and a lawyer, and she's also the Senior Vice President of Government Affairs at Premier. In this role, she is responsible for developing and implementing Premier's advocacy strategy to lead the transformation to high-quality, cost-effective healthcare and resilient supply chains. Dr. Saha proactively advances legislation and regulatory actions that address the vulnerabilities in our healthcare system. Her work directly resulted in the introduction and passage of the Mitigating Emergency Drug Shortages Act, which was signed into law as part of the Coronavirus Aid, Relief, and Economic Security Act in March of 2020. Since COVID-19's public health emergency, Dr. Saha has helped the nation's hospitals and healthcare providers through the pandemic with innovative legislative solutions that have resulted in a suite of regulatory flexibilities from an incredible number of organizations: the Department of Health and Human Services, the U.S. Food and Drug Administration, the Centers for Disease Control and Prevention, the Federal Emergency Management Agency, and the White House. So we are very lucky to have her here to speak with us about what's going on in Washington. Welcome, Shoumi.
All right, good morning. Just a few things going on in our nation's capital. So, here are some ground rules. You guys know that I like to have some fun during these presentations. I also know that this group knows how to take a joke or two. So, bear that in mind as we go through all of this. I put slides together at about 11 p.m. last night, so things are accurate up until that time. Things will likely change in the hour that I am up here. I did provide these slides to be shared with you, so you can get them in a PDF format afterwards as well. All right, so just a little bit about Premier and our presence in DC. I have the honor of running a bipartisan, nonpartisan DC office, which is unique and different because when we all come to the office, we don't talk personal politics. We put that all besides us. And the only goal in how we develop policy is to put the patient back at the center of healthcare. Everything we do is about the patient, and we do that by leveraging our vast data assets. As a clinician, I always say that I was taught to practice evidence-based medicine. As an advocate, we practice evidence-based advocacy. Now, we look at our work in 4 different buckets. How do we optimize the value of healthcare? How do we make sure that reimbursement's keeping pace with the cost of providing care? How do we build out more resilient supply chains? How do we bring healthcare into the 21st century and truly leverage technology to enable how we care for patients? And how do we eliminate those gaps in care? How do we move from a sickness-based healthcare system to a wellness-based healthcare system? And turns out that when you keep your head down in DC and you focus on what is in the best interest of patient care, you can truly get a lot done. These are just a smattering of our accomplishments within the first 9 months of this administration. And there is a key word that you will see on this slide over and over and over again, and that is bipartisan. Regardless of what you see in the media and what you're seeing in the news and reading on your social media feeds, bipartisanship still very much does exist in DC. And that is the cornerstone of our work. And so, we're gonna have a lot of partisan conversations today because that is the current state of affairs. But I want you to know that behind the scenes, there are lawmakers that are in DC for the right reason, and that is to leave this country better than they found it. May not always feel that way, but I promise you they do exist. All right, and I know that the Yankee Alliance team is the best team. However, I have a pretty amazing one too, and this is not a one-man show. We have an amazing DC-based team. Each one of these individuals has their area of subject matter expertise, so please know that this is a full team effort. Okay, We're going to talk about where we are today. We're going to talk tariffs, everyone's new favorite dirty word. What's going on from a supply chain resiliency perspective, where we are with drug pricing, a little call to action, and then I'm going to open it up for Q&A. There is no way that we can cover everything that's going on from a healthcare perspective over the course of the next hour, so I please encourage you to ask questions. Let's chat afterwards, or please never hesitate to reach out via email if it makes sense for us to connect on a very specific topic. Sounds good? All right, so the current state of affairs in Washington, D.C. I went through this a lot, and I ultimately decided that I needed to resurrect a slide that I used at this conference about 3 years ago. Here it is. Now, I used AI for this, right? So how does our DC office use AI? To make fun images for PowerPoint slides. I don't know how else to describe where we are today, okay? It is a legitimate dumpster fire, and the dysfunction is real. Now, the question becomes, how did we get here, and how did we get to this point of this dumpster fire? So, we have a Republican White House. President Trump is back for his second term with Vice President J.D. Vance. Now, a lot of folks thought that Trump coming back into the White House would be copy-paste from the first Trump administration. And we were the first to say, no, this Trump isn't exactly the same. He's very different. He's kind of got a bone to pick, and he's got something to prove. And so things are going to be different this go around. And there are 5 major themes that we are seeing this Trump really put forward. First, how do we reduce waste, fraud, and abuse? I will admit it's really hard for me to say waste, fraud, and abuse because I'm so used to saying fraud, waste, and abuse. But in this administration, waste comes first. Very clear when you talk to them. 2, how do we decrease federal taxpayer spending? Huge focus on not just decreasing savings, but making sure that taxpayers have more dollars in their pockets come April of every year. 3rd, deregulation. There's a goal here that for every new regulation that is put forward, you have to undo 10 regulations, 1 in, 10 out. I always joke, if I could do that with my shoe closet, we'd be doing a lot better from a closet space perspective. But reality is, prior Trump said 1 in, 2 out. He's now saying 1 in, 10 out. So up to the stakes there. 4th is about America first. Everything is about America, America, America. That is the goal. And the 5th one is all around how do we reduce chronic illness? How do we reduce this country's chronic illness burden? And you're seeing a lot of that come to fruition under the Make America Healthy Again initiative, MAHA. Now, while these are very 5 public things that they are pursuing from a healthcare perspective, there are 2 unspoken rules with this administration that you need to be mindful of. Number 1, they're running the government like a business. They want it to be efficient and lean, enter Doge. They also want to make a deal. They want people to come to the table and negotiate just like you would in a business transaction. And the second part of that is not just let's make a deal, but we want you to self-regulate. Deregulation is really intended to say we want industries to self-regulate. So let's talk a little bit about some of these deals and self-regulatory policies that were coming forward already. You are seeing the insurers come forward and say, oh my gosh, we are so sorry about all of those prior auths, denials, delays that we put in place. We're gonna do better. We're gonna decrease the number of PAs, denials, and delays moving forward. The EHR vendors have come forward and said, oh my gosh, we are so sorry that we've been blocking information from providers and patients. We're going to do better about that. The PBMs are now coming forward. You saw Cigna yesterday announce that they are going to do away with rebates. PBMs are in the process of putting forward a voluntary pledge to create some transparency standards. You are seeing the food industry voluntarily come forward and start removing some dyes and other additives from their foods. Why are they all doing this? It's because if they don't do it themselves, the administration will do it to them. And there is an opportunity to step forward and self-regulate, cut your own deal, and avoid some of that political ire. Does it solve your issues in the long term? Not necessarily. But does it buy you some time before new laws or regulations impact the industry? Yes. Now, there is one key industry that I noted or did not note as far as making a deal, coming forward, and self-regulating. And that is the healthcare provider community. So keep that in the back of your mind as we talk through some of the challenges that are forthcoming for the provider community. All right, so Republican president. We also have a Republican House and a Republican Senate, the trifecta, if you will. So why in the world are we where we are today? Well, this concept of tight margins. In the House, you need 218 seats in order to have a majority. Republicans have 219. The real magic number in the House is 290. That's how many you need to actually get a supermajority. With one person being the majority, that means that every single voice and vote counts. And that is why you are seeing this cast of characters have so much power. The cast of characters has always existed in every single administration and every single Congress. They were just powerless because they were just a number. They have so much power now, and P.S., there's this thing called social media, right? So they have a platform to be powerful on. In the Senate, 51 is the magic number for the majority. But what you really need is 60 votes to overcome something called the filibuster. And Republicans now have 53. So they can only afford to lose 2 votes. And in order to get anything done, they actually need to find 7 Democrats who agree with them and will vote alongside them. So alas, here we are in this deadlock. A fully Republican trifecta doesn't necessarily mean that you are paving the way to do whatever you want, whenever you want, because there's still challenges with these tight majorities. Which leads us to, what has this administration and Congress been able to accomplish thus far? The biggest one, and really the only one, is that on the 4th of July, the president signed into law the One Big Beautiful Bill Act, known as OBA, or the cool kids in DC now call it OB3, kind of like a little Star Wars reference. What you need to know about OB3 is the following. It is expected that it will reduce Medicaid expenditures by $1 trillion over the course of the next 10 years and reduce the number of individuals insured under Medicaid by at least 10 million patients. The interesting part here is that you will recognize that none of the provisions go into effect until December 2026 at the earliest. Most of these provisions don't go into effect until 2028. So you may be thinking, and a lot of folks are out there thinking, I have time. This is not something I need to worry about today. Let me be real with you. You have to start preparing now because this is not going away. There are a lot of folks out there, a lot of trade associations, folks in DC that are like, well, Congress is never going to actually allow this to go into effect. What they're going to do is delay it year over year, similar to how Medicaid DSH cuts were actually passed 15 years ago, have never actually got into play. Congress annually delays them year over year. Now, the reason that this is very different, Medicaid DSH cuts as an offset cost about $8 billion a year. It's relatively easy from a DC math perspective to find $8 billion a year to make those DSH cuts go away. This is $100 billion a year. Does anybody have any ideas on where you can cut $100 billion worth of expense out of healthcare in order to offset what was just done? And that, my friends, is why this is not going away. And that is why we need to start preparing today. If I could put a plug in for Andy's presentation this afternoon, he's going to be talking a lot more about tactically what providers and others can do to help overcome some of these headwinds that are definitely forthcoming. Now, what else has this administration done so far? Well, nothing. Welcome to day 28 of the government shutdown. This is now the longest full government shutdown. And so what does that mean? Every year, annually, the government runs on an October 1st to September 30th fiscal year. Theoretically, every year prior to October 1st, they have to pass 12 individual budgets for different departments. Those 12 budgets then come together from all of the different departments and creates the universal government budget. This year, we were not able to pass a single one of those 12 individual budgets, let alone the big budget. So this is why it's considered a full government shutdown. The last major shutdown was in 2018. That went 35 days. It was under the first Trump administration. That was considered a partial shutdown because they had passed some of those 12 department budgets, so it wasn't 100% everyone's out. How many days will this government shutdown last? Well, look, if there's one thing that this administration loves to do, they love to be number one, and they love to beat records. And that includes beating their own records. So I'm going with at least 36 days is what my money's on, if 35 was the prior. We are no closer to getting out of this shutdown today than we were 28 days ago. And for the first time, one of the first times, healthcare is the only reason that this shutdown is occurring. And let's talk a little bit about the ACA enhanced subsidies. So, once upon a time, the ACA had these enhanced subsidies to help lower the cost of the premiums for members. During the pandemic, to address some of the unemployment challenges, the income levels were actually increased so that you were still eligible for these premiums. And then when the Democrats passed the Inflation Reduction Act 2 years ago, they actually extended those subsidies through December 31st, 2025. Now, the debate here right now is that Democrats are standing strong and saying that they will not agree to any type of budget unless if extension of these ACA subsidies are included. Extending these costs about $40 billion a year in their current format. So we need to go find $40 billion. Republicans initially were under the impression that they weren't going to touch this. This was a Democratic problem. Dear Democrats, Republicans have never voted for this. You're the ones that extended it to December 31st. But post OB3, even Republicans are realizing that if they vote against ACA subsidies or don't do something in this space, it could be political suicide going into the midterm elections. So Republicans' position now is, okay, we'll make a deal with you, dear Democrats, but you have to figure out how to pay for this and how to offset that $40 billion in expense. And alas, here we are with the shutdown. Democrats have yet to come to the table with how they propose to pay for this. Now, there are other things that are being considered, like maybe we lower the income level, all of the above. Now, this is one of the pressure points that folks are hoping will help end the shutdown. On Saturday, November 1st, all of the rate notices in all 50 states for the exchange plans will go out. And there's some hope from Democrats that the sticker shock that individuals note when their premiums go up, and on average, it's expected that premiums will go up somewhere in the 18 to 24% range per household. It's a lot of money. That will spur calls to their local lawmakers to try to address this. But I'm going to tell you a little secret. It's too late to change anything for 2026. You guys all know how benefits are run and what happens. They've already locked and loaded everything for 2026 at the insurance companies. All of the systems have already been updated. Open enrollment has already opened in many states. It's too late to change anything for the 2026 benefit cycle. So there's a couple things that could happen. One, they could get to a deal, keep 2026 benefits as similar to 2025 as possible, and extend open enrollment beyond January 1st so folks have more time to pick a plan. Or you take the hit for 2026 and you fix this for 2027 and beyond. But the bottom line is nothing is happening between today and Saturday to make this all change. Those premium notices are going out this week. And individuals will be hit with that sticker shock. It's too late to change anything. Okay, with the government shutdown also came the expiration of several key healthcare programs. The two that I want to really point out here are the hospital at home program. So on September 30th, anybody who had a hospital at home patient was told you either have to discharge that patient or get that butt back into a hospital bed. Those were your only options. So hospital at home for Medicare does not exist in this moment. If you still have patients that are being treated from a Medicare perspective, hospital at home, we may need to chat and we may need to lawyer up, right? Telehealth, that is the other thing that expired. So outside of claims for mental or behavioral health or rural telehealth, which already existed pre-pandemic, if you are still providing telehealth services to Medicare patients, you are technically currently doing that out of the goodness of your heart. There is no guarantee that you will be paid for any of those services rendered post-October 1st. The interesting part from a shutdown perspective is that theoretically the impact to healthcare is fairly minimal. And the reason is Medicare and Medicaid payments continue to go out. Can't say the same for all other industries, but for the most part, healthcare has been insulated, and the Medicare Trust Fund does cover a lot of these expenses. Now, not only is November 1st a trigger point because of the ACA rate notices going out, but SNAP benefits in many states will run out of dollars on November 1st. We also have to talk about federal employees and their paychecks. So October 24th, all furloughed employees missed their first official paycheck. The military will be technically missing their second paycheck. Will be missing their first paycheck. It's supposed to be their second, but we found money to pay them 2 weeks ago. We actually decreased some of the research dollars at the VA and DoD to find about $8 billion in savings that were used to pay the military. Paying the military payroll every 2 weeks is about $6.5 billion. So there's $1.5 billion left over from those savings that were found. And yesterday, an anonymous, not so anonymous donor donated $130 million to the DoD to help pay the troops. All of that equates to each troop member will get a paycheck, but it's not going to be their full paycheck right now, unless if we can find another $5 billion or so laying around. So those pressure points are all coming into play here, whereas the first month of a shutdown is kind of like, other than if you want to go to a national park, that's going to be closed. You're not really missing paychecks. It doesn't really impact an individual. Once you start getting into day 28 and beyond, it really starts mattering. So, options out of here. Option number 1. The House had actually passed what's called a continuing resolution. A continuing resolution is a kick the can, let's keep the government running for a little bit longer until we figure this all out. The House had actually passed a continuing resolution to fund the government through November 21st. And then the House left DC, yet to be seen for the past month. They haven't been back in town. The Senate could theoretically decide that they're going to pick up that CR that the House passed and vote on that, get it done, at least fund the government through November 21st, and then figure it out. Why that's not going to happen is because the number of congressional days between now and November 21st are very minimal. That's not enough time for them to come back to DC and negotiate those 12 individual departmental budgets that then have to come together for the bigger budget, right? They need more time, so it's not going to happen. Option number 2 is that the House is probably going to come back into DC next week. They are probably going to pass an updated continuing resolution that funds the government conveniently through like December 24th. Love that, right before the holidays, and or into like the first week of January. It's also possible that we will see the House actually pass multiple continuing resolutions with multiple dates and just be like, here's a menu, Senate, pick whatever date works best for you. Option number 3 is that they actually do what's called a full year CR. So all the way through September 30th, 2026, we will pass a budget that's 100% copy-paste from what we had in 2025. And they could potentially also do that all the way through the end of the calendar year, December 2026. Why that's not popular is if you do a full year continuing resolution, you are fully admitting that Congress is 100% defunct and plans on getting nothing done between now and the midterm elections. That's not good from an election perspective. And 2, earmarks. earmarks go away. So a lot of hospitals, local community providers work with their lawmakers to get additional dollars as part of the budget cycle in order to build infrastructure in their local communities. And those dollars are really important to providers. Those dollars don't exist if you do a full year CR, so it actually hurts the hospital and provider community to do something like that. And then the fourth option, which is referred to as the nuclear option in DC, is that the Senate actually has avenues in place to pass legislation using the simple majority 51 votes. Now remember I said you need 60 votes in the Senate to avoid the filibuster? The filibuster is when the opposing party can get up there and talk for as long as they want. Delay tactic, okay? There are avenues available to Republicans where they can pass legislation with 51 votes, but they have to suffer through the filibuster. And are they willing to do that, and have they gotten to that point yet? According to Republicans, no. So what's likely going to happen? Option number 2. I envision the House coming back next week. We'll get a continuing resolution into December at minimum passed, and then that buys the Senate additional time. There's also talks right now about let's go ahead and just start paying the federal workforce. Laws were passed in 2019 after the last shutdown that guarantees federal workers back pay. So they're like, why are we even pretending? We're going to pay them anyway, so let's go ahead and start paying them. And that's to alleviate some of the heat that might be forthcoming as well. So at least 36 days, and we'll see what happens there. Okay, here's the bad news. If you for a second thought that what happened in OB3 is where it ends when it comes to the belt tightening for healthcare, I hate to tell you this, but that was only the beginning. Let me tell you something you already know. During the pandemic, healthcares were heroes, right? Remember everybody going outside at 7 p.m., wringing their pots and pans and so excited? And the reason that we were heroes is because we were united. We were all in it together. It didn't matter if you were a large health system, a small provider, if you were in an urban area or rural, if you're for-profit, nonprofit. No one cared. The only thing that mattered was the patients coming through our doors, and we were united in what we were doing, and we became heroes. We have literally in 5 years managed, from the eyes of DC, gone from heroes to literal zero. And part of that challenge is because of this lack of unity amongst the healthcare provider. We tend to focus so much on what differentiates us that we often forget to talk about what unites us. Is there a single provider out there who thinks that reimbursement is great and is 100% covering the cost of care? Is there anyone that has no supply chain challenges whatsoever? Is there anyone that is 100% staffed and has no labor issues whatsoever in their facilities? Is there anyone that thinks that healthcare is the easiest to navigate, completely not burdensome, and you know what? We are so in the 21st century from a technology perspective. No. There are things that unite healthcare, and we need to focus on that. And remember that concept of let's make a deal and let's negotiate and self-regulate? These are the threats that the administration is making on healthcare. Site-neutral payment policy. Do you know how they're going to pay for the ACA enhanced subsidies if they do extend those? Most likely site-neutral payment cuts. Most likely. That's coming. You get one, you give. Changes to the 340B program, also likely coming. Changes to the inpatient-only list, also coming. Changes to upcoding in Medicare Advantage programs, also likely coming. What I'm telling you is that the barrage of options that are available to this administration to further tighten the belt of healthcare are many, and they are not afraid to use them. In fact, some of these things on the regulatory column are likely to be finalized this Friday as part of the physician fee schedule and outpatient prospective payment system rules that are expected to be finalized. This is the uphill battle. And so it doesn't end at OB3, it starts at OB3. Now, I didn't promise that this discussion today was going to be uplifting and bright, but this is the reality. And we've got to stop pretending, right? Why are challenges to 340B program? Do you know what a lawmaker literally said on Thursday of this week during a hearing? Why is a 340B hospital buying a Super Bowl ad? You're not poor. You don't need that program. You're misusing those funds. Hospitals aren't poor. They have plenty of money. They're buying naming rights to stadiums. The optics matter from a DC perspective. I know what you need to do from a marketing perspective. I know what you need to do to increase your patient share and increase your revenue because reimbursement is so tight. But just think for a second of how that comes across to lawmakers who 100% have your future in their hands. Gotta be mindful of optics. You have to be as you wish to appear. So, should we talk about tariffs? Because why not? Get happier. All right, here's the bottom line with tariffs. The tariff landscape remains fluid and dynamic, which is a very nice way to say it's a hot mess and no one really knows what's going on anymore. Look, here's what you needed to know. Regardless of who won the White House, Republicans or Democrats, we knew that tariffs were going to be a topic of conversation. Why did we know that? Trump 1.0 actually initiated tariffs on healthcare items. They went away during the pandemic, and Biden actually brought them back and doubled down on them in September of 2024 before he left the White House. So we knew, regardless of which party won, we were going to be talking about tariffs. And once we knew that Trump won, we knew that this administration doesn't want to hear no. Right? If you say no to them, you lose your seat at the table. We're also not going to go out there and be like, yeah, tariffs on healthcare sound great. Please have at it. So we actually launched an advocacy platform pre-inauguration that said, all right, Trump administration, let Premier and our members help you put two of your goals together. You want to tariff, we get that. But you also want to spur American ingenuity and drive domestic manufacturing. What if you took the tariff dollars generated from healthcare and reinvested them directly back into the healthcare supply chain? And they were like, wait, that's not a terrible idea. The question is, how do you actually do that? So interestingly, while the president has a lot of authority to collect tariffs, they almost have zero authority to actually spend tariff dollars. And so we are stuck in a bunch of lawyers from the government trying to figure out how to siphon dollars that came from healthcare back into healthcare. Similarly, right now, you may have heard the president say he wants to use tariff dollars to pay furloughed workers and the troops. They can't figure out how to actually do that. So you can collect all the revenue, but spending it is very difficult. And what we have said all along about tariffs is that when used in a targeted and thoughtful manner, they do have a purpose. But when you go too fast, too furious, you are really risking supply chain disruptions. And when you go too fast, too furious, the only people that are left holding the bag at the end of the day are the provider and the patient. And we need to be mindful of that, especially with the way that reimbursement is squeezing providers today. So, there are multiple different levers the president has to collect tariffs. Reciprocal tariffs that have been collected thus far, this is the per country dollar amount that you were seeing out there. Those are all under this fourth bucket, IEEPA, the International Emergency Economics Powers Act. There's also something called Section 232 tariffs, Section 301 tariffs. What you actually need to know is that Congress is who actually has the authority to implement tariffs. But year over year, Congress has actually ceded that authority to the president. So it's not actually the president that has this power. It's Congress, but Congress has given that power to the president. Where we are with the reciprocal tariffs is the Supreme Court next Thursday on November 5th will be hearing oral arguments regarding whether or not the president exceeded his authority under IEEPA to implement all of these reciprocal tariffs. No, the Supreme Court does not shut down during a government shutdown. They're still open and running. You can't go watch the oral arguments like you normally could because security is furloughed at the Supreme Court, interestingly enough. But the justices and everybody else is there. The most interesting part about if these IEEPA reciprocal tariffs are overturned, the government's collected about $1 trillion in tariff revenue under these authorities. If the Supreme Court overturns this, technically the government has to refund all that money. They can't keep it. Now here's the bottom line question. How do we get that money back to the end purchaser? That money's going to be returned to the importers. Yes, they'll be made whole. But how do you get made whole if you bought supplies at a higher rate because of tariffs? And not just from a healthcare perspective, in your personal lives, how do you get reimbursed for the things that you bought at a higher rate because of tariffs? That's a huge outstanding question. Interestingly, there are a lot of banks betting on tariff returns right now, and people are like putting out money back guarantee type of programs to say that they're going to help you get your dollars back that you've spent on tariffs. So it's really interesting to see how Wall Street is now engaging in trying to take a cut of this $1 trillion return potentially. Now, what you need to know is even if the IEEPA authority is overturned, there are still other levers that the president can use, and we are seeing this come to fruition in healthcare. So the administration did formally launch a 232 investigation at the pharmaceutical supply chain several months ago. This is about seeing if the pharmaceutical supply chain and national security intersect, and from a national security perspective, should tariffs be implemented on pharmaceuticals. Premier had submitted really detailed comments here around the need to focus on essential medications. Not all drugs are created the same. Let's also make sure that we're looking at the APIs, key starting materials, excipients associated with these drugs, not just the finished dose. What about if there's a delivery mechanism associated with that drug? How are we taking that into account? And P.S., tariffs alone are not enough. You also need to invest in domestic manufacturing X, Y, Z. We also saw on September 23rd at like 9:37 p.m. So we love policymaking via social media under this administration. So about 9:37 p.m., my phone's going off. The president announces 100% pharmaceutical tariff on branded and patented drugs for manufacturers that are not actively building a manufacturing facility on U.S. soil. And P.S., those are going to go into effect in 7 days on October 1st. What the heck does that mean? All you have is a tweet, right? There's zero details. So we had way more questions than we had answers. Now, this was a negotiation tactic. It was a scare tactic. And what ended up happening is that these tariffs have been delayed indefinitely while the administration continues to negotiate one-on-one with 17 drug manufacturers that they have identified as being high priority for cutting deals with. We'll talk a little bit more about what those deals have been in a second. The administration also just yesterday announced that they're likely going to be launching a Section 301 investigation into the pharmaceutical supply chain. Why are they doing that? To give themselves options. So if IEEPA is turned down, they can go 232, they can go 301. Bottom line is, guys, tariffs on healthcare are here to stay. They're gonna find a way. They're not gonna go away. And we've got to figure out how to prepare for that. And then we also saw a 232 investigation into the medical device supply chain launched as well, similar to the pharmacy space, trying to figure out the intersection of medical device supply chain and national security and whether or not tariffs can be implemented using this lever should IEEPA be overturned. And if you were wondering what the DC office's Halloween costume is this year, we're all really excited about these shirts that we got. Look, we got to have some fun from a policy perspective, okay? One of my team members walked into like one of those Halloween stores. I'm like, you're not going to believe what I just found. I'm like, what? But yes. Okay, supply chain resiliency. The president has been doing a lot from a supply chain resiliency perspective. They lived the pandemic. They know that the healthcare supply chain needs work. But what they really need from us is to be educated on what's working, what's not working, what's still left. I had a conversation with the White House in late February, early March, just talking about some of the things that they can do to better support the America First agenda. So some of the conversations that we had were around, hey, did you know that when a generic drug manufacturer submits an abbreviated new drug application to the FDA, it's first in, first out? You could have a Chinese manufacturer and an American manufacturer submitting an application for the same exact drug, but if China had submitted first, they get reviewed first. There's nothing from the FDA that says America first. They're like, no, we didn't realize that. We also had a conversation where I said, hey, do you know that from an FDA inspection perspective, actually manufacturing on US soil is quite the deterrent for manufacturers, because you know that you're going to get inspected annually, you know you're going to get inspected unannounced. Whereas if you're manufacturing overseas, maybe they show up every 3 years, and they're going to tell you when they come so you can clean up and be better. So it's kind of a deterrent to be on US soil. You've really got to figure out how to shore up international versus domestic inspections. And then in April, we got an executive order that actually incorporated a lot of what we had shared with the administration from an educational perspective. This, hey, FDA, you need to prioritize American applications moving forward to support domestic manufacturing. Hey, FDA, you've got to figure out how we're going to level the playing field for inspections for foreign facilities and domestic facilities. And then how we also get the EPA to better coordinate with the FDA for a lot of the permitting requirements, and then how we also coordinate from a national level to help manufacturers navigate everything that's happening at the state and local level from all the permits and permissions that they need to build facilities. So part of this America First agenda is the FDA has announced a pre-check program, different than the TSA pre-check program, but pre-check, which basically says that the FDA moving forward will help expedite and prioritize US-based manufacturing. Comments on this are actually due the 30th, so tomorrow. We just submitted comments earlier this week, and we said, look, it's great that you're putting this program together, but maybe in lieu of focusing on innovator products only, you also focus on the generic industry, recognizing that many of those drugs are essential, subject to shortages, and the products that we need most in our hospitals and acute care facilities. And also, again, not just the finished dose, we've got to talk about API, key starting materials, the excipients, everything that goes into that manufacturing facility. And P.S., why stop this program at drugs? Why not also look at critical medical devices as well? So where this goes from here, we're not 100% sure, but we're glad that the administration is at least thinking about how to help support that domestic ingenuity. A couple things that are uniquely Premier, and one of the things I want to pause and say thank you to this room for is for your ongoing support of Premier's advocacy efforts. Yankee, your members have been amazing when it comes to, hey, do you have any data to help support this? Or can you help us create the echo chamber for this legislation that we're really trying to support? And I just really want to say thank you. So one of those pieces of bipartisan, bicameral legislation is this Medical Supply Chain Resiliency Act, which would create trusted trade partnerships. It sounds simple. We know we can't bring everything back on US soil, but we need countries that we can partner with where we don't have to worry about tariffs, where we don't have to worry about export embargoes, where we can have friendshoring, if you will. Trusted trade partnerships exist for other industries like energy, does not exist in healthcare. This is a piece of legislation that 50+ organizations have joined us in supporting. While a government shutdown stinks for many reasons, it's actually a great time to get a lot of work done behind the scenes because you can get people to focus. We actually just got something called technical assistance back from the Treasury's office on this piece of legislation. It's when they redline bills and they give you their okay on it. And so we just got that back. So when Congress officially reconvenes, we are hopeful that this is something that we can get done during this Congress because now Secretary Bessent and the White House has signed off on it as a concept. Do you know what I had to do from a red line perspective? I had to change the word tariffs and duties because they don't want the word tariffs in there. And I was like, well, can I just switch out the word tariffs to say trade restrictions? And they were like, yeah. I was like, great, done. Control-Alt-F, easy peasy. All right, the other key things that we have in motion, we have a domestic manufacturing bill that we are so close to getting done. We have Senator Marsha Blackburn from Tennessee and Mike Kelly from Pennsylvania on the bill. We just got the thumbs up from the White House that this is supportive of their America First agenda. And so now that we have sign off from the White House, we can get the Democrats on board and get this done in a bipartisan, bicameral manner. How Premier is thinking about onshoring and domestic manufacturing incentives is different than what many others have thought about it, and that's because of the supplier partnerships that we have and our ability to communicate with suppliers about what's working, what's not working. So we look at it as, it doesn't matter where you are in the US. There's a lot of other bills out there that say you have to be in an opportunity zone. What we've heard from suppliers is that it's really hard to hire skilled labor in an opportunity zone. And so you really need to have carte blanche as to where in the country you go. The other thing we wanted to do was reward those that are already on US soil, already doing the right thing, but are still not at a price competitive point because, let's be honest, it's more expensive to manufacture on US soil. So it includes a tax credit for those that are already here, already doing the right thing. The goal is to take price out of the equation and let our purchasers and buyers focus on quality, resiliency, sustainability. The other piece of legislation that we've been working on is around just transparency into what is on US soil during a pandemic. Why don't we know where the ventilators are, but we knew where the Snickers bars are in this country? We've got to fix that. We need some transparency and visibility into the healthcare supply chain. Where are the things that we need when we need them so that we can move product to the area of greatest need quickly. Okay, and then crazy idea that we just put forward. Myself, Justin Schneider, who leads our pharmacy GPO team, just published a byline 2 weeks ago. Simple idea. We said, you know what the DEA needs? The DEA needs a chief pharmacy officer. All of the challenges that we have with getting quota allocated for controlled substances and all the downstream shortages that occur as a result of that, you know what would help? If we helped the DEA move out of their law enforcement mindset and move into their clinical care mindset, which is also a key component of who they are and what they are responsible for. This would also help with prescribing of controlled substances via telehealth, or when they reschedule drugs like tramadol and hydrocodone, when they got rescheduled, caused a lot of havoc. Or this administration, Trump actually has been talking about rescheduling cannabis and psychedelics for medical use. So when and if they do that, somebody at the DEA needs to understand the clinical implications so that that is done in a way that providers and patients can navigate. All right, 5 minutes on drug pricing. Okay, look, here's what you need to know. Trump 1.0 was all about lowering drug prices. And if you remember, he took some super aggressive approaches to this. Everything got stuck in the court systems, and ultimately nothing was implemented. So Trump 2.0 was gonna come back and figure out how to do this without getting stuck in the court systems. We saw an executive order on drug pricing come out fairly immediately. A lot of talk in here about most favored nations, getting acquisition costs from hospitals. That's because they're gonna change 340B reimbursement. That's why they're doing that. That's why they want your acquisition costs. And on Friday, when we anticipate CMS finalizing that OPPS rule, they're putting that into a conditions of participation, likely. So if you don't tell the administration what your acquisition costs for drugs are, they can pull your right to provide care to Medicare patients. And that data will be used to change 340B reimbursement from ASP plus 6% to ASP something else. Keep that in mind. Okay. A lot of folks thought that Trump was going to do away with the IRA. We always said no. I think he's going to double down on the IRA, put his own little tweaks on it, and that is exactly what we're seeing. The IRA continues to move forward regardless of the government shutdown. These employees are considered essential, so they are there, they are working. January 1st, 2026, first 10 drugs. Then we have this most favored nations approach. This got stuck in the courts last Trump administration. And when he started talking about it again, I initially said I wouldn't lose sleep over it because, from my perspective, there's no legal mechanism that the US government has to compel a drug manufacturer to disclose their privately negotiated contract with another country to actually get to the MFN price. Secondly, there is nothing that actually precludes a drug manufacturer from increasing their international prices in order to raise the MFN price for new launch drugs. And you've seen companies like Eli Lilly come forward and be like, you know what we're gonna do? We're just gonna raise our prices internationally. They've literally said that. Now, this Trump, let's make a deal. Remember that? So what we have seen is drug manufacturers are coming forward and starting to make deals with the administration. So Pfizer led the charge here, followed by AstraZeneca. EMD Serono is the most recent. There were 17 total notifications that went out from the White House to drug manufacturers. We anticipate 14 additional deals to be announced in the near future. Some similarities with these deals: all of these manufacturers agree that in the Medicaid program, they will offer their drugs at an MFN price. My question becomes, I have yet to figure out in what circumstance an MFN price is lower than the already existing Medicaid price. Great optics, let's make a deal, but did you actually give up a penny? They also promised that in the future, for new drug launches, they will launch at an MFN price in the US. Again, what stops them from raising their prices internationally, leveraging rebates, et cetera, not losing a penny? All right. The other thing is that they all agree that they are going to make their products available on a future to-be-announced website that's going to be called TrumpRx. TrumpRx is going to be, from what we understand thus far, where manufacturers can pull together their patient assistance programs. It's still not clear right now if you can actually buy and have a drug dispensed via TrumpRx. That's what they're trying to figure out right now from a partnership perspective. But some of these drugs that are forthcoming are already offered at that cash price discount. Like EMD Serono has said that their products are going to be offered at an 84% discount via TrumpRx. I can tell you the cash price for their drugs are already at an 84% discount, not losing a penny. Now, what do these manufacturers all get in exchange? A 3-year reprieve from any tariffs implemented on pharmaceuticals. Huge for them, right? And EMD Serono also got a priority voucher for their new product, which will minimize the amount of time that FDA requires to review that from 12 plus months to 1 to 2 months. That means 10 more months of market share and exclusivity for them on that drug. So these negotiations are great for the White House to demonstrate their power, but really I think the pharmaceutical industry has just demonstrated a masterclass in negotiation here. Masterclass. All right, here's what you need to know about midterm elections real quick. November 2026, 100% of the House of Representatives is up for election. 1/3 of the Senate is up for election. Almost always, 100% of the time, the president's party loses the House. It is almost positive that the House will flip to Democratic control in November of 2026. The question becomes, by how much? Will they get to 290, which is the number you need to really have a supermajority? Probably not. They will probably still have some really tight margin where every single vote counts. The Senate right now, total toss-up as to what happens with that. Now, you are also seeing a lot of states redistrict right now, and that's going to play a role in whether or not the House gets that supermajority with Democratic leadership. But that's basically what we're anticipating in November, is that the House will likely flip, Senate complete toss-up, but neither will flip with a sufficient supermajority either way. Oh, and has a government shutdown ever impacted the midterm elections? No. It doesn't matter, right? And both parties know that right now, which is why they're not incentivized to get out of it, because they know it doesn't matter from a midterm perspective. And with that, here's my call to action. Help us help you. I and my team can only do our jobs because it's folks like you that bring your pain points to us and share what is keeping you up at night and help share, hey, this regulation is so outdated, way out of scope, help us fix this. It's because of you that we have all of these genius ideas on how to fix a lot of this. But what I also need your help with is focusing on what unites us, not what differentiates us. That concept of be as you wish to appear. There's a lot of data that Premier has, but there's a lot of data that we don't have. And so anytime that we can reach out and have you help us gather some of that data so we could take that evidence-based advocacy approach, we appreciate that. And most importantly, just remember that it's all about the patient. We all chose healthcare because we wanted to leave it better than we found it. And I just ask you to remember that as our North Star as we think through the chaos of our day-to-days, the chaos of whatever is happening in DC. As long as we remain focused on the patient, I promise you, we will leave it better than we found it. So with that, I will open it up for any questions. Oh, and if you don't get our newsletter every Monday, this is a little QR code that you can subscribe to our little newsletter. All right, questions. Oh my gosh, who wants to start? I think Casey's got a mic.
Quick question for you. So since both Trump 1.0 started tariffs on healthcare, the healthcare industry, and Biden continued them, and now they've been, expanded even further. Do you believe it doesn't matter what party is in power, that tariffs on healthcare industry products will continue, number one? And then number two is, if that's true, what is Premier doing and what should members in the room be doing to engage with and proactively try to partner with American manufacturers for the future?
Love the question. So yes, do I think that tariffs on healthcare are here to stay regardless of who's in power? The answer is yes. The outstanding question is, will they be blanket tariffs applicable to everything? Or can we get the administration to understand that not all drugs and devices are created equal? And so we're trying to get them to focus on essential versus non-essential. Now, there are a lot of essential versus non-essential lists out there, and we can all argue about the merits of each one. None of them are perfect, but at least it's a starting point. And so what we're trying to say is that essential medicines, essential devices can't absorb any additional tariffs on them because those supply chains are so fragile, et cetera. And also, you need to provide time. You can't build a manufacturing facility overnight. You're looking 3 to 5 years at minimum, not just physically building the facility, but the whole regulatory process to get approved, right? So our goal is to figure out a way to get away from a blanket, everyone's the same. Slow, steady, glide path approach is what we're moving towards. How do members and others navigate this, right? Because the number one question you're getting from your CFOs is, what is this going to cost me and how is this going to increase my supply chain costs, right? So goal number one, and I know Andy will go deep into this later, is look at your GPO contracts. Most GPO contracts have a firm for the term price. Manufacturers, put your earmuffs on for a second, right? But that can help at least provide a minimum level of insulation for a period of time. The other thing is, for areas where you don't have a GPO contract, you need to look at what are countries of origin and who has the least impact. So in lieu of purchasing from a country that has 100% tariff, maybe you can move to another supplier that has 0 because it's domestic, or maybe 10% because it's one of the countries that's cut a deal. All of this is to say, leverage your Yankee and Premier team members as partners to help you figure this out, because it's very complicated, it's changing every single day, and know that we are just working really hard to protect the fact that the dollars don't exist in healthcare to absorb these shocks.
Hi, Shomi.
Hi.
I have a quick question for
Sure.
you. I'm wondering if you have any insights to what strategies are being considered to ensure equitable access to health care services across rural and underserved communities?
Love that question. So, what's really interesting with this administration is, we've seen a lot of the DEI type policies from the Biden administration rolled back, and that was very clearly known was going to happen. This administration is still very focused on diversity, but they use the word very differently. For them, it's about geographical diversity, not necessarily racial or ethnic diversity. And so huge focus on rural communities and how do you ensure that all Americans have access. And as part of what happened in OB3, we saw that come to fruition because they recognized that OB3 was going to hit the rural communities the hardest. And so what they did put forward is something called a $50 billion Rural Transformation Program, which is supposed to help augment the dollars flowing into those rural communities such that those services remain available for rural patients. one of the challenges there is that the state has to apply for those dollars. And then one of the other challenges when we were submitting comments on how to administer the program is we wanted the dollars to go closest to the actual healthcare providers. What we didn't want to see was like consultants or random third parties come in and take those dollars, take 20 to 30% off the top to administer those dollars. We want 100% of those dollars to go directly to the healthcare community. And so I think there's a tremendous focus on rural healthcare. You know, you didn't ask this question, but I'm going to go ahead and build on it. When you look at all of the pressures that are about to come to healthcare, one of the questions I'm asked often is healthcare too big to fail? Are they going to let healthcare fail? And at what point does service rationalization turn into there's no longer access to care, right? And there's debate about this going on from a policy community. There's a tranche of people that think that they're going to take us to the brink of failure and then pull us out like they did the financial markets or the automobile markets, that they'll figure a way to pull us out. And then there's another tranche of thinking that's like, yeah, they are going to let you fail, because it's not until you fail that we can blow up the system and recreate it, because it's so complicated. And that's the real question. Will they let us fail? Because right now, we're not being set up for success, that's for sure. Any other questions? Okay. I'm all open to recommendations on how to make this more uplifting. You know, normally I have a lot more jokes. I don't know, we could talk about football instead or something. But it's not good, guys. It's not good. And I think from a supply chain perspective, what you're going to see immediately, and if you haven't already, is your C-suite leaders telling you to take X dollars or X percentage out of your supply chain costs in anticipation of some of these changes that are forthcoming. And so if you already haven't had that conversation, know that it's coming. Okay. Thank you, everybody, so much.